What's up, Doc Mike? Public Health on Call, by Johns Hopkins Bloomberg School of Public Health. Today's topic for November 25, 2020. COVID-19, racism, and kidney disease. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak to Dr. Deidre Cruz and Dr. Tangela Purnell of the Johns Hopkins Center for Health Equity. Our topic is COVID-19, racism, and kidney disease, the subject of a great new paper that they have authored. We speak about the concept of weathering and how racism and discrimination are responsible for an enormous amount of preventable kidney disease, leading to unnecessary suffering and premature death. Let's listen. Thank you so much, Dr. Cruz and Dr. Purnell, for joining me to talk about COVID-19, racism, and racial disparities through the lens of kidney disease. Maybe I'll start with you, Dr. Cruz. You're a nephrologist, and you, with Dr. Purnell, have studied disparities and inequities related to kidney disease. Let's sort of set the stage. What are we talking about before we even get into 2020?
Yeah, so when we think about the health inequities that exist in our country and really across the world, they are tremendously profound when it comes to kidney disease. And just for a few examples, so when we look at comparing Black Americans to white Americans, the rates of kidney failure are more than 3 times that among Black individuals when compared to whites. And there are tremendous disparities in access to care with regard to kidney care. And there also are disparities in access to the optimal therapy for kidney failure, which is transplantation. And that's an area that Dr. Purnell has worked a lot in.
So Dr. Purnell, what explains these disparities and inequities with respect to kidney disease, which are pretty striking with those statistics?
Absolutely. And thank you for allowing us to talk about this very important topic. So we know, looking at the national data and also local data, that diabetes and hypertension are the 2 leading causes of diagnosed cases of kidney failure. And unfortunately, we know that Black Americans and other so-called racial and ethnic minority groups are also among the hardest hit when it comes to these conditions as well. We also know that this is not necessarily a reflection of people being born to just be predisposed at such a wide magnitude to this, debilitating condition. What we know is that there are social conditions. And in fact, we talk in the article about structural racism, meaning the different ways by which society foster racial discrimination and opportunities for housing, education, healthcare, employment, you name it, and how all of these things sort of come together to help explain what we see in terms of the burden of kidney failure and the disproportionate impact on Black Americans.
Great. Could you maybe spell out a little bit more for people who haven't thought about kidney disease very much, how these social injustices wind up in the end of the day with such high rates of kidney failure, transplantation, dialysis for certain communities?
Absolutely. So I can start talking about, for example, Dr. Cruz brought up a lot of my work related to transplant. And I know that a lot of her work focuses on, for example, the food environment. And so I'll start by talking about how this sort of plays out in terms of differences in treatment access, in particular in what we know to be the optimal therapy for those eligible, which is transplant. And so, for example, one of the things that we know is that getting a transplant versus long-term dialysis basically results in a much better quality of life and a longer life expectancy for patients. However, there are significant disparities in terms of who gets access to a transplant at every single level, starting with who has access to a nephrologist or kidney specialist prior to ending up with complete kidney failure. We know that the timing of this is important in terms of being referred and being able to make it through the very lengthy clinical evaluation process so that you can potentially get on the waiting list for a kidney if the kidney is coming from a deceased donor. But then we also know, that a lot of people are pushing for transplants from living donors. But then we think about things like the burden of chronic illness in the communities and the fact that many living donors are relatives. We think about, well, who would those donors be? And also just the lack of widespread education and knowledge about what that entails and who is eligible. So these are some of the ways that these systems of structural racism play out in terms of treatment access.
Got it. Dr. Cruz, did you want to add something?
Sure. So I would just like to sort of share, I think, an example when we think about even upstream from before someone might develop kidney failure and a need for kidney transplantation. And that would be just sort of thinking about what raises risk for developing kidney disease in the first place. And some of those are, we know that, as was said, the two leading kind of attributable causes for kidney disease are diabetes and hypertension. And so if we focus a bit on diabetes, right, so thinking about the role that a healthy diet plays in prevention of obesity and diabetes and how closely linked those two things are. Well, it is well documented that in communities that are predominantly Black, as well as in communities that are predominantly Hispanic, and many of those same communities also are predominantly sort of inhabited by people with low incomes, that those communities have less access to healthy foods. And so that is one, I think, example of sort of structural inequities that then downstream can lead people to not be as able to follow the types of healthy diets that we might recommend for prevention of diseases like diabetes and hypertension and ultimately kidney disease.
Got it. Well, thank you both for drawing those connections. So we have this situation of a lot of patients at risk, a lot of structural inequity responsible, and now we hit 2020 and things have gotten worse. So maybe I'd ask you, Dr. Cruz, first to talk a little bit about COVID and what that's meant for kidney patients.
Yeah, so I think with COVID, I think probably the first population in the kidney community that we were first concerned about are our patients who are treated with dialysis, particularly those that are treated in a center with hemodialysis. And that is because they have to come in usually 3 times a week for these treatments. And so and it's sort of a congregate setting, right? So raising the risk of exposure to other people, other patients, as well as the staff members, and the risk to those staff members working in these facilities. And so that's been a concern. Some of the early cases in Seattle, for example, did involve dialysis patients being infected. But, beyond that, there's also been a lot of concerns around some of the types of health services that kidney patients need on a pretty frequent basis in order to maintain their health and maintain their ability to undergo their treatment for their kidney failure. And that includes the vascular access procedures that they need in order to maintain a kind of a conduit between their body and the dialysis machines that we connect them to in order to kind of perform the dialysis procedures. And so those procedures were, in many cases, canceled as a result of COVID because they were not considered essential in a lot of places. And so there have been just a number of different impacts that we're seeing for kidney patients.
And so the result is people may have less access to dialysis or not as effective dialysis or infections from their old procedures. And that just like adds and adds and adds.
Absolutely. Yeah.
And so, Dr. Purnell, if you could talk about your paper that you wrote with Dr. Cruz, where you introduced the concept of weathering, that as these different challenges layer on top of each other, it creates even more problems and threats. So could you explain a little bit of what you mean and how that has been reflected in both the pandemic and other events of 2020?
Absolutely. So the weathering hypothesis, which we mentioned in the paper, was first proposed in the 1990s by Dr. Arlene Geronimus. in which, she basically asserted that, Black Americans experience early decline in their health as a consequence of repeated experiences with adversity over the entire life course from birth to death, essentially. So, when we think about things like even in utero, some of the negative exposures that Black children now face, and we now know that these types of things have an effect even in later health conditions. And so, essentially what it's saying is that now here in 2020, we basically make the case that this COVID-19 pandemic, on top of these very high-profile cases of violence against Black individuals, are yet another adverse experience for Black Americans to, quote, weather. And so we know that this has a cumulative effect on both physical health, mental health, but then also in the case of kidney disease, thinking about issues like trust, and thinking about issues like fear of medical institutions, and thinking about the history of this country, both historically what has happened, and also currently thinking about some relationships that certain members of the population have with the medical encounters are not pleasant experiences. And so when we talk about, topics like organ donation and transplant, and then we have to now layer it on top of, watching in real time as Black individuals are being gunned down, or, people feeling as if Black lives are being marginalized, and now, trying to, really make headway in terms of addressing equity and things like access to transplant, where we have to really trust our doctors and really trust the health system to do the right thing. Or in the case of asking family members or loved ones to donate an organ when they're not sick. So basically asking them to come and put themselves potentially at harm's way if that's what you're concerned about. Right. These are all things that have very real consequences in real time.
So it is a key part of the weathering concept that we can't look at these things in isolation, that it's not just like, well, there were problems with kidney, disease, access, fairness, causes, all those things before, but let's just put those to the side. And you've got COVID and another pile of challenges, and you've got racism and a third pile of challenges, that you just can't look at them in isolation because they're all happening to the same people. And the challenges and the particularly, connected perhaps, as you said, by trust, but the challenges kind of compound each other. Is that part of weathering?
Absolutely. And it's not just single individuals, generations of abuse, essentially, at this point, or even, being communicated about generations of abuse. And so, we can't really approach populations and come to them and say things like, oh, your distrust of the medical community or health system is irrational, or it doesn't make sense, when we haven't really lived through the exact same experiences or walked through those shoes. And so I think that this is absolutely what we're saying. All of these experiences matter. They all count. And just making it out of one adverse event, if you're lucky, doesn't mean that you're not still impacted by the effects of what it took to make it out of that event. So definitely, it all plays a role.
Yeah, it's cumulative, I think, is the key to thinking about it. And I think an important thing, I think some of the work of David Williams highlighted this, and colleagues highlighted this issue of sort of vicarious trauma, sort of not only these experiences that Black individuals and other sort of marginalized populations may experience themselves sort of directly, but that there's also an effect when you witness these things as a sort of vicariously, and that those have also been shown to have these negative impacts, and they also are things that have to be weathered. So I think the cumulative piece of it is what we were trying to highlight.
Now, I know that you both are more than observers on this issue, that, you work on these challenges every time you're in the clinic, Dr. Cruz, and both of you are in communities talking to people, you're writing medical journal articles, you're speaking at national conferences. When you have this challenge that's sort of greater than the sum of its parts, what are the kinds of answers that that you are calling for it. And it could be an answer for an individual, a community, or for our country as a whole. I'm just would like to hear how you think about the way out of this.
Yeah, I mean, I think to start, I think the first way that I would think about it is that each of us has a role to play in this. And I mean that at a very high sort of societal level, that every one of us, I think, has a role to play in dismantling these structures that have led to what we see today as far as these inequities. And so, when I, as a clinician, when I think about what an individual clinician can do, for example, when they're seeing a patient, one of the things that we even highlight in our article is that really just the first thing is just to acknowledge it, just acknowledging that the person sitting in front of you may have experience these things, maybe weathering these things, right? I think is so key, and to, especially in this time, to acknowledge the grief that a lot of people are experiencing. And then I think from there, we all, health professionals, public health professionals, I think really have a duty to use the platforms that we have to both try to study these issues and provide the evidence for not just sort of documenting that the problem is there, but also developing solutions. I think that is so key, and that there should be, and I'm excited that hopefully there will be greater commitment to doing so.
Dr. Purnell?
So I absolutely echo what Dr. Cruz said. I think, thinking from the more so the research and education side, public health education, public health practice, I think that, really the first thing is that we all collectively have an obligation to really talk about the nuanced complexities of how we are measuring race, what it means, and also thinking about the role of structural racism, thinking about the role of differences in social, political, and economic barriers, and how these collectively lead us to many of the observed differences by race in a lot of our outcomes across the board. So I think that number one, that, we as individual researchers, educators, students, journal editors, funders, peer reviewers, we all should be collectively, bringing each other to task and being held accountable to do more sophisticated analyses which are needed. I think the next thing is that collectively, we have an obligation to do more for these communities than, to simply write about death and pain that are being experienced at disproportionate levels by marginalized communities. We, not to sound cynical, but, this is what we hear from the communities. We hear that many times their only experiences or encounters with researchers or, medical or public health professionals outside of the clinical encounter are when people are applying for grants or just got grants or are trying to complete studies that ultimately will get published, will get funded, will lead to promotions for that individual faculty member or, student or whomever, trainee. We have an obligation when we see these injustices, when we write about what's going on, we have an obligation to do more. And we have an obligation to partner with trusted agents in these communities and people with lived experiences to ask and to be humble enough to listen when they're telling us what we need to do in order to actually help the communities that we serve.
So people are listening and interested in what would make a difference for this cascading series of challenges. What would be on your list?
Yeah, so I really think that each and every one of us can use our platform, because I believe that all of us has a platform. Some of us have greater platforms than others, but I think some of the types of things that even at the local kind of level that we could advocate for are some of the challenges around some basic needs that people of color in many communities and also people with low incomes in many communities are struggling with, and it's been magnified in the setting of COVID. And those are things that we think about, like when we think about housing and some of the longstanding injustices around access to high quality housing that we know that could be in communities that would be health promoting for people as opposed to health detracting. And so advocating for greater housing supports for people who may be newly finding themselves having insecurities around their housing status would be one place. And then we have been seeing spikes in the number of people that are experiencing food insecurity during this time. So having difficulty accessing food, both due to economic reasons, but also due to the fact that a number of food outlets have had to close as a result of COVID and the mitigation efforts. And so getting engaged there around either individually supporting people who may be struggling with accessing food, but also advocating for those policies that expand coverage for programs like the Supplemental Nutrition Assistance Program or the Food Stamp Program, I think are ways that each of us can get involved.
So even though you're a specialist in kidney medicine, some of the solutions to these major challenges facing your patients and many patients with kidney disease are kind of right in front of our eyes.
Absolutely.
Great. Well, thank you both so much for taking time to talk about your new paper and these really important challenges and potential solutions.
Thank you.
Thank you for having us.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.